Welcome to I'm Not a Pharmacist, the podcast hosted by someone like you who's not a pharmacist. Hello, I'm Geoff Redick, former television news reporter, now a public relations professional, but definitely not a pharmacist. We are sponsored by the Pharmacist Society of the State of New York, also known as PSNY, and we are bringing education on pharmacy issues to the consumer. You can watch the show on YouTube and listen wherever you get your podcasts. This is our first episode, so what can you expect? Well, a lot of me asking a lot of questions that you might ask. We're going to translate a lot of what's going on in the pharmacy world into very understandable little pieces and information. So, things like, why do your prescription drugs cost so much? What do different medications do? What are those people in the white coats doing all day when they stand behind the tall counters at the pharmacy? So let's get started. Our first featured segment on every episode is Drug of Choice. And that means I'm going to sift through the news, figure out what pharmaceutical news that we talk about and what it all means. So without question, over the past few weeks, the top story in pharmacy news is the Change Healthcare cyberattack. Now, Change Healthcare is what's called a switch company. They make sure your insurance money gets where it needs to go. So for prescriptions, for example, if you pay prescription insurance, you pay the insurance company pays Change Healthcare, and then Change Healthcare pays the pharmacy. Your electronic prescriptions that are delivered by computer also go through the switch company, in this case, Change Healthcare. Now, at the time we're recording this, Change Healthcare has been a victim of a cyber attack. The company has said it was by a, quote, nation-state actor, and at the time of this recording, at least, the cyber attack is still crippling that company's ability to handle switches, again, those payments between payer and insurance and pharmacy, and that all led to some prescriptions going unfilled because they couldn't be paid. Plenty of New York pharmacists actually continued filling prescriptions with a paper doctor's note, just like we used to do way back when, and figuring that they would later submit those for payment in the electronic system. But we're going to be talking to a pharmacist in a bit about exactly why this hack and relying on the payment later is no guarantee. So more on all of this in just a bit. Next up, and this is important for anyone who's struggling or knows someone struggling with opioid addiction, New York has re-upped its standing order on anyone being able to get a naloxone prescription at any pharmacy. Very few questions asked, too. So this drug, naloxone, is sometimes more commonly called Narcan. That's the brand name. It's the drug given through the nose, and it stops the body's receptors for opioids like heroin and fentanyl. So someone in the midst of an opioid overdose can literally be saved by naloxone. Happened countless times all over the United States and elsewhere. This is why it's so important, because literally anyone, even a young person, can walk now into a New York pharmacy and buy a naloxone kit. And the kids might just be asked a few questions, but they can get one too. Even the pharmacist, under this order from New York State, can actively recommend that someone take home a naloxone kit if the pharmacist thinks that that would be a good idea. So if someone comes in who's shown a tendency for opioid addiction or overdose before, or the pharmacist knows there's a family member at home who's at risk for overdose, then the pharmacist can just hand out that prescription. This is in New York, but exists in a lot of other states. Very important development for opioid addiction in New York, for sure. And finally, in this segment, Drug of Choice, if you or a loved one lives with HIV, news for you, very important. The Federal Drug Administration has just expanded the indications, that means like the rules, that can allow for a prescription of Biktarvy. This information comes to us from Pharmacy Times. Biktarvy is from the drug maker Gilead. Essentially, it combines several medications into one single pill for people who've been fighting HIV successfully and need to be on medication to keep holding down the virus. Now, this expansion makes Biktarvy accessible to people who have a resistance to other drugs that do the same job. Those drugs are called NRTIs, and as many as 2/3 of HIV patients don't respond well to NRTIs. They have what's called a resistance to those. Biktarvy is an ISTI, different thing altogether, but essentially it does the same job for those resistance patients. A study showed at least 89% effectiveness with the drug, might even be higher. This is also important because once HIV becomes resistant to a treatment, that's it. That resistance is permanent and irreversible, according to Gilead. So this new drug expansion, again for Biktarvy, for HIV patients, very, very important. And that's the end of our first segment on our first ever podcast. You're listening to I'm Not a Pharmacist, podcast about pharmacy hosted by me, Geoff Redick, and I'm definitely not a pharmacist. And that brings us to our second segment. This is a Pharmacist, where we bring an actual New York pharmacist on to talk about the industry to someone completely uninitiated like me, maybe like you. So here's Steve Moore, pharmacist from Northern New York. He owns Condo Pharmacy in Plattsburgh, New York. He's also associated in community pharmacy associations and pharmacy benefit management. Steve, that's an ugly world. We'll get into that. But thanks for joining us, Steve, on I'm Not a Pharmacist.
Yeah. Hey, Geoff, I'm thrilled to be here today. So hopefully I'm not going to put your audience to sleep.
You make it look sunny there and green in Plattsburgh. I doubt that's the case today.
I've got to. It's psychological, you know.
What's it like being up there in that area? You know, you're like the northernmost city, I think, where we've got pharmacy members.
Almost. We're pretty much Southern Canada.
Yeah.
It's a beautiful area, beautiful part of the country, part of the state. We love our four seasons. Maybe we could do with some more sunlight once in a while this time of year. But it's a great area to be in.
We got people all over the state and all over the country listening, Steve. What would you say your rural pharmacy out there? I know it's a city of Plattsburgh, but what's it like?
Yeah, so Plattsburgh's a big city north of Albany. Between Albany and Canada, Plattsburgh's our big city. So about 20,000 people, 25, and we've got the SUNY students in town. Probably twice that in an immediately outlying area. So, a decent population center, lots of great people, great community, and this pharmacy's been here since the 1940s. So, we're thrilled to continue the legacy from the Condo family, last name of the original owner. So going on, 90 years coming up soon.
Yeah, just a little bit. That's it. Pharmacy's only been around a little while. But let's break down the Change Healthcare hack, Steve, because we talked earlier about pharmacies not getting paid. We'll talk about that again with you. What about patients? What does this mean for them?
Yeah, so it's an incredible challenge depending upon where you live. In a lot of situations, Change may be processing more prescriptions in one area of the country than in others. There are a few states where Change is actually processing Medicaid prescriptions, for state Medicaid agencies. So obviously that's a big patient population and a big group to be affected. Here in New York, we're seeing issues with Medicare Part B billing. We have a lot of pharmacies that use Change to bill Medicare Part D, and that could be for immunizations. The CDC just recommended another COVID booster for seniors at a time when we may have trouble processing those claims through Part B now. So
does that mean you're not getting a shot? You're not getting a prescription if you're a patient?
It could. It absolutely could. If a pharmacy can't submit a claim, how do we know if a patient's eligible? With all of this COVID therapy, it moved to the commercial market. Whereas when it initially came out, we were given these products by the government, so it was, hey, get these shots in arms. But if we have to pay hundreds of dollars a dose, to administer these, we probably have to make sure that patient's eligible. You know what I mean? We want to make sure that we're going to be able to cover our costs and to afford to buy that, the next box for the next set of patients.
And that's so hard, Steve. You guys are so patient centric. I mean, you are the one who faces the patient at the pharmacy level. Nobody else does that in the industry. That's such a tough decision for you guys to make.
They'll see Change and they'll have no idea how it actually affects them. In the case of patients with commercial insurance, Change will process a lot of manufacturer discount cards. So if somebody who's on a brand name med who might be getting, $50 worth of assistance a month, $100 worth of assistance, those claims aren't going to go through. So is the patient going to have to pay that out of pocket? Does the pharmacy put that on a charge account, try to rebill later? It can be real tough with cash flow for pharmacies when stuff like this happens. We pay for drugs on a weekly or biweekly basis. So, when you start talking the dollars involved, it can add up real quick.
I don't know if people understand too, when you talk about that, let's talk about you pay for drugs. You're like a retail store, even when it comes to pharmacy. You buy supply and you sell it sort of through this insurance, Change Healthcare, PBM world. But people may not understand that. You have bottom lines to meet. You got profit margins to make, right?
Yeah, and we have bills to pay. They come a lot quicker than sometimes the money comes in. So cash flow can be a definite challenge in pharmacy. You can grow your way out of business very quickly if you don't have the funds to manage, increased bills. And, unfortunately, that's just a reality of our situation. Nobody is getting rich dispensing prescriptions. There's a lot of money that changes hands, but a lot of what comes in goes right back out the door pretty quick.
Yeah. How far does this go? I mean, do we know, is patient data at risk? Are they going to get their identity stolen through this? Do we know that?
At this point, the group has been very tight-lipped. So Change Healthcare started out as a single entity decades ago. It's gone through a number of iterations, but it was most recently bought by United Health. So one of the biggest insurers, one of the biggest companies in the world now owns this.
We talk about that vertical integration of healthcare, right? Yeah.
Absolutely. And they're saying that this is isolated to the change arm, if you will, right now. Um, but I mean, we're going on 3, 4 weeks of they haven't been able to get this fixed. So do we really know what the exposure is? Probably not. Probably not at this point.
How can people ensure when the system breaks down and there's a whole system, but when that system or part of the system like this breaks down, how do people ensure, Steve, they get their medications? Can anybody ensure that? Can you ensure that?
Yeah, I'll tell you what, as a pharmacist who's across the counter from our patients, we live and work in the communities with our patients. We're going to do our damnedest to make sure our patients get their medications. And this is where it is incredibly important to have a relationship with your pharmacist, just like you do with all members of your healthcare team. If I'm dealing with you, you're coming in every month for a prescription, every 3 months for a prescription, and your copay card is down. You know what? Let's put that on a charge account and we'll get this sorted out in a month when this is worked out. I know you, you know me, we've got that relationship. It's a lot easier to take care of patients that we have a history with than it is for somebody coming off the street that we're meeting the first time.
Yeah. I mean, would you say you have that relationship? Look, I've been going to the pharmacy. Everybody's been going to the pharmacy for a long time. Particularly, I go to a grocery store pharmacy, Steve. I don't necessarily know those people. I don't think they know me. Well, how is it different for you in your independent pharmacy?
Yeah, I mean, I just think, by virtue of the fact, I'm an owner, I'm more interested. You know what I mean? There are a lot of great pharmacists that work for a lot of great pharmacies, no matter what type of pharmacy it is. I think, though, when it comes to community pharmacy, there's an incredible value to knowing who it is behind the counter that you're dealing with. And that's the entire pharmacy team. I don't want to sell, obviously, I'm biased, I'm the pharmacist, but I work great clerks with great.
You're the owner, man. You run it.
Well, I try. It runs me. It runs me most of the time. But we have a great. Our delivery driver. The delivery people are sometimes the face of the pharmacy to a lot of our community because people can be shut in, especially this time of year. They're not going out a lot. They see the driver more than they see the pharmacy. Now we can mitigate that with technology. Now we've got a lot of tools. We can use FaceTime to talk to people and everything. But I think having that relationship in a time of crisis is incredibly valuable because it's just that much easier to take care of patients that we already know that we can allocate, we can say, hey, this is down, but I expect it to be up in a week, so this is what I need to do. It just makes it a lot easier when you've got that relationship in place.
This is a tough question, and answer it how you will. Are pharmacists going to give medication away for free during this hack? Have they been doing that?
Yeah. Sometimes, and I think to the degree that we can, I don't want anybody to go without medication, but at the same time, if we start to get, if you start to get to, okay, I've been through my existing stock of a medication and I haven't been paid for it, how do I afford to reorder? You know what I mean? How do I, if I don't have those dollars coming to the bank from the insurance company, how am I going to pay the wholesaler for the next round that I need to order? So that's where the challenge, is margins don't support much more than what we're actually doing. To save a bunch of money in pharmacy right now is incredibly difficult given the margin pressure we're seeing, from the PBMs. It's predatory, to be honest with you, what we're seeing for some of those groups. And I hope that the FTC comes down on them pretty hard, pretty quick, because we're already starting to see pharmacies close.
So let's talk about that now, the system. You just got into a little bit of, first explain to me as brief as you can, because this is a word it makes no sense to me, this term, but I get it. Vertical integration. What is vertical integration in healthcare? What do we mean?
Yeah, so I think in the idea in the pursuit of efficiencies, we've kind of grown and allowed some of these companies to become vertically integrated to the point where if you look at our journey, our healthcare journey, from the physician or the nurse practitioner that you see, to the pharmacy that you go to the insurer that is paying for all this stuff, it's all owned by the same company.
So one company?
One entity that controls your entire healthcare journey. And they may have different arms. You look at a group like United Health or CVS. CVS started out as a pharmacy. They bought a pharmacy benefit manager called Caremark. So they became CVS Caremark. And then they bought a health insurer, Aetna. So they control your health journey, from cradle to grave in a lot of cases. And I think we're starting to see some of the problems associated, with this vertical integration. And, the Change Healthcare thing is just one big glaring instance of maybe why peak efficiency isn't what we should be pursuing, in our healthcare. It should be quality over everything else. And I think that's starting to suffer with this vertical integration.
So dumb question here, but I want to hear you answer it and make more sense of it. Why this is one company. Change Healthcare's one company. One company got hacked. Why is that affecting so much in healthcare?
Because there's only two or three of them that work in the space, unfortunately.
Switch companies like Change Healthcare?
Yep, switching companies. So there's only two or three really big ones that work in the space. And so when one goes down, actually there may be four now. I apologize, but
Oh, good. Now there's four.
Change has a pretty outsized market share in some areas, and it's kind of like I said at the beginning. The impact can depend entirely upon where you are. Like if you have a patient, if you're a Medicaid patient who's the state Medicaid group uses Change to process prescriptions, you probably have no idea about that. You know what I mean? Like, what does that mean to you? Nothing, except for the fact the back end processor is now down, and that's affecting patients differently in one state than it might in another. Um, but we should have redundancies in place, and unfortunately, I don't think that we have the ones we need in place right now.
How did we let this get to be a problem like it is now? I mean, where does this go back to?
I think it's the for-profit healthcare system. I think it's a reflection on the idea that we're pursuing profits for shareholders instead of quality and outcomes, and it's incredibly unfortunate. I'm as capitalist as it gets. Excuse me. Don't get me wrong.
You're a business owner, Steve.
I'm a business owner, right? But when it comes to healthcare, the pursuit of profit can't be the only goal, and it can't be the overriding goal. I think we have to take care of patients first, and I think if we do that, everything else will work itself out.
Is anyone working to regulate this federally, the state level, anywhere? Anybody trying to stop these switching companies? I mean, being four of them.
Yeah, so unfortunately, the horse has left the barn with a lot of this stuff already, with this vertical integration. What we're seeing here in New York, we are incredibly happy with the work of our Department of Financial Services, what we call DFS here in New York. They're working to regulate this industry, whether it be PBMs or pharmacy benefit managers, whether it be groups like these switching companies, anybody that controls and can ultimately impact the distribution of and the provision of healthcare. So DFS in New York is really stepping up, and this instance is probably going to lead to some regulations and some rulemaking once we get this sorted out.
Meaningfully, do you feel like there's more to go here?
Oh, there's a lot. We're very early on in this trying to figure out this space. These groups have done their best to. They've deliberately made this harder than it has to be. These PBMs they've been asked to comply with an FTC investigation, a 6B investigation, and we just find out, a week and a half ago or so that three of the big ones, haven't even sent the information the FTC's requested. So these groups are so big that they think they don't have to comply with these governmental agencies. Or if I had the FTC knocking on my door, I'd be bending over backwards to work with them so I didn't end up in jail. It's like they just don't have the same incentive right now. And I think we're going to have to see some people punished for it.
In the face of this, like I'm one patient, and I don't even use pharmacy that much. I'm lucky. But I'm being affected by this. Clearly, you're being affected by this. But what does one person do? What do we do in New York nationally can we stop this? Can we stop it from affecting healthcare?
Yeah, I think we can. I think we absolutely can, and I think we have to start to take control of our own healthcare journey. Instead of being, like you, I don't necessarily utilize a lot of healthcare services. Obviously, you hear my voice. I've talked to my PCP this past week.
You sound fine, Steve.
We have to take control of our health journey and our information. We've got to know what's going on with our insurance plan and what those changes every year mean. We get those notices of change and what's going on and what the formulary is and all this other stuff. I don't think that we can be passive observers anymore in our own healthcare journey, because we may not need a ton of help right now, but there's probably going to be a day when I do, and there are people who do need help. And what is it that we can do to make it easy for them to get that and cost effective for all of us, so that, we're certainly spending enough on care, but I don't know that we're getting the outcomes that we should be. And I think that we have to demand better. It's tough when we get our health insurance through our employers. You know what I mean? Even as a small group employer, I don't have a ton of control over which plans I offer or what's available.
Mm-hmm.
But, we do every year. I at least insist that I'm enrolled in a drug plan where I can fill my own prescriptions. It's my way of fighting back. But I think that we need to get involved in, be active politically, whether or not you're a Republican, a Democrat, or an independent, you need to be engaged in this conversation. It's too important for us to sit on the sideline. And it's okay to have different opinions and different ideas because we can come together for the best possible solution.
All right. That's a lot. Thank you. That's the end of our second segment here. And, the podcast is called I'm Not a Pharmacist, and I'm not. There's one thing I do know, I'll admit, about pharmacy, and that is that there are massive companies right now called PBMs. Steve's been talking about them. Pharmacy benefit managers, they actively work to destroy competitors, small businesses like condo pharmacy, competitor pharmacies, and they do that because they got to please shareholders. They control what pharmacies get paid. They make more money because of that. And then they'll tell you, even with almost no regulation on them in the market, federally and the state level, they'll tell you everything's fine in pharmacy. Everything's great. Pharmacies are getting paid. Pharmacies aren't closing. It's a rosy picture. So we are ending each episode of I'm Not a Pharmacist on a rosier, happier note called Put On My PBM Hat, where I'm going to embody the happiness of a PBM and put on my PBM hat. So today, this is my first hat. And some people might only be listening, not watching, Steve. Can you explain just what my hat is for those who are only listening? Describe this for me.
Yeah, well, the hard hat's definitely a great idea, and the fireman's hat is a great idea because there's a lot of fires these PBMs have got to put out.
Notice what it says on the front, Steve.
Oh, it's too far away from the camera. I'm
sorry.
It
says fire chief.
Fire chief. Charge, okay. Steve. You were creating these fires and putting them out.
So my hat is on now, Steve. I'm a PBM now. Okay. I'm a PBM. Steve, what I do is I make sure everybody gets paid in the pharmaceutical space. I pay drug makers a fair amount, right? And I like insurers like to work with me, right, Steve? And most of all, I get you paid, Steve, the pharmacist, because I'm a PBM. I'm a pharmacy benefit manager. And we have we had a hack, a cyber attack last week. But look, the fire, we're putting it out, okay? Things are going to be great, Steve. Let's be honest. The system could not work better than it does with me in charge, right?
I'd respectfully disagree. So,
Steve.
I agree. We've given you a little bit too much authority and a little bit too much power. The arsonist can't be the fire chief as well. It's just not going to work.
Arson. That's a strong word, Steve. We love each other. I'm having trouble keeping my PBM hat on here. I don't know if you can see that. So, yeah, we had that cyber attack last week. We just kind of have to live with this. But we can do it together, right, Steve? We're both going to come out of this stronger than before, right?
I don't know. I don't know about that one. I think, unfortunately, the stress on our community pharmacy system is reached a breaking point. I think we're seeing pharmacies close every week. There were 10 that just closed in Pennsylvania last week because specifically PBM practices. Here in New York, I'm hearing from colleagues that are struggling to pay their bills. And I know the PBMs are going to be just fine. You guys are doing record-breaking quarters every year.
It's fine. It's great. Yeah.
You guys are doing great, but those dollars could be going to the distribution and provision of care and instead of the shareholder pot.
No, okay. We'll agree to disagree, Steve, because that is what we do, definitely. Look, I know a lot of you, and you're saying it. I know you want to be unhappy about the cyber attack, and your fellow pharmacists want to be unhappy about the cyber attack. I think things are great. The best thing is we're going to come out of this stronger than ever, and I don't think there's going to be any more problems in the future because, look, we only got a couple companies that are really in charge, controlling everything. So I can't see this happening again. I don't see a threat. And I imagine you don't.
Yeah, no, I think we're just seeing the very beginning, unfortunately. These groups, this vertical integration, these are big dollars, big targets, lots of data there, and it's scary what some of these groups are going to try to do.
Steve, we're supposed to be friends here. You joined my network, right? You joined.
Didn't have a choice, but that's another story. These adhesion contracts and everything. That's a tough one for the podcast. That's for sure.
Look,
but it's so many.
Steve, I'm a PBM. I love you. I love pharmacy. I'm a pharmacy benefit manager, Steve. That's what we're set up at. Look, I can ensure that you get a fair reimbursement, right? And I think I just need to take home what I and my shareholders need. We're all going to make enough at the end of the day to survive. Just enough.
No, not likely. Not likely. So, but appreciate the effort. That's for sure. But I think, we start to look at what's going on. We were really lucky here in New York. We kicked the PBMs out of our Medicaid program last year, saved $410 million in the first year.
And I miss you so much.
Yeah,
Steve.
you miss us in
I miss
Medicaid.
you a lot.
We're saving more than $500 million in the second year here in New York. So I think that's a model that we've got to look at in the commercial and Medicare D markets. And I'd encourage every state to look at it in their Medicaid programs too.
Steve Moore, everyone. What a great job handling the first ever segment of Put On My PBM Hat. Whew. All right. Well, Steve, thanks so much for joining us on I'm Not a Pharmacist. We hope to have you back here real soon. And that's I'm Not a Pharmacist. Episode 1 is done. I'm Not a Pharmacist is a monthly podcast written, researched, and produced by the team at Baker Public Relations of Albany, New York. We are supported by the Pharmacist Society of the State of New York. Find us on YouTube to watch the show and listen wherever you get your podcasts.